There being none, Dr. Hudson, I would like to call on you to read the mission statement and vision, if you would.
Certainly. Our mission statement is to improve the health and wellness of Nashville by providing equitable access to coordinated patient-centered care, supporting tomorrow's caregivers, and translating science into clinical practice. Our vision is to be a leader in exceptional community health care, one neighbor at a time.
Thank you. Do we have any public comment?
Yes, sir. Ms. Lori
I
Darnell.
call on Lori Darnell.
Good evening. My name is Lori Donnell. I'm the Senior Vice President for Health Affairs for Meharry Medical College. I'm here today in response to the allegation D in the Nashville General Hospital quality or not audit. Meharry Medical College did our own investigation regarding this allegation concerning our provider, Dr. Billups, providing care in the Nashville General Hospital space. From that investigation, we have determined that we will be self-reporting to CMS, returning funds to both the Medicare, Medicaid services, as well as we're choosing to return funds to the other carriers. There was not significant enough findings in the revenues so that we don't have to do a major self-reporting, just a letter in our practice management system of about $5,000. Thank you.
Thank you, Ms. Donnell, for clarifying that. We will defer the minutes from the February and March 10th meetings because our recording secretary has been busy with everything we're giving her as well as a family emergency. They'll be deferred to the next meeting. Under old business, PSA update. Mr. Esquivel, or would you defer to someone else?
Yeah. Christy Lewis is going to give the report. I was unable to attend the most recent meeting, but she and I spoke this afternoon, and I think it'd be better to hear directly from her. So I've asked her to give the report.
Thank you.
Good afternoon. My name is Christy Lewis, Chief Compliance Officer for Nashville General Hospital, here to provide an update on the progress for the professional services agreement. I'd like to acknowledge both Dr. Southpaw and Ms. Donnell, and as well as the Meharry team for their continued participation, and as well as the progress that we have been making. For the last two meetings, we have made the most significant progress in terms of red lines and in terms of documentation as far as the content of the PSA. The most encouraging thing is that we were able to change the term date. We are looking for the term date of July 1st. We have also increased the cadence of our meetings for every 2 weeks. That is showing both progress and for that. Among the things that we discussed in there are including further clarification on the credentialing requirements from the GME. We are also having a clearer articulation of our payment processes. We have an implementation of joint committees that are addressing joint hires for both the institutions, as well as a financial committee that is comprised of both Meharians and Nashville General employees as well, to address not only the fair market value payments, the payments for residents, and to articulate a clearer process so that it is firmly documented in the PSA. Again, we look forward to meeting the new term date that we have for July 1st. We appreciate the partnership and the continued progress that we have between the two entities.
Thank you. Any questions for Ms. Lewis? Dr. Elders, any additional comments about this?
No, sir. We're excited about the progress and look forward to the continued collaboration.
Right. Thank you for your report. Next, I think last month we had a new conflict of interest policy that we reviewed but had not been reviewed by the legal department, and so we're bringing it back today. Mr. Smith.
Go ahead. No, go ahead.
if it's acceptable, I'll report from here. Ms. Lewis and I have met in a phone conversation or a WebEx approximately 2 weeks ago, and we've continued to review the policy, and the actual disclosure form 2 is currently under review. Our objective is to consolidate some of the overlap of the categories to shorten the policy, which I think currently is around 8 or more pages. And the recommendation is to get that condensed to be a little bit more understandable and quicker to work through. And then the disclosure form itself also may be condensed a little further. So we'll have a final report. Plan is at next meeting.
Okay, thank you. Any questions for either Ms. Lewis or Mr. Smith? We'll look forward to seeing that. That should be in the packet, I guess, for the April meeting, and hopefully we'll be able to approve that. Moving on to the department reports. First, medical staff bylaws status. Dr. Katz.
Good evening. The Bylaws Committee has now met twice. Our third meeting is Monday. It was pushed back because all the doctors were with their children at the beach 2 weeks ago. I will have more to report, but progress continues to move along. Again, this represents a bipartisan, all-partisan, collaborative effort in the spirit of working together in years to come. We continue to work on a document that all parties are and can anticipate being comfortable with. That's all I have to share today. Thank you.
Any questions for Dr. Katz? All right, thank you very much. Credentials report, Dr. Miller.
I attended the Medical Executive Committee last week. We had 5 initial appointments, including Dr. Brandon Allen in internal medicine for Bordeaux, Carl King, physician assistants, internal medicine, Metro Center, Stephen Miller, orthopedic surgery at the main hospital, Ashley Nickerson, general cardiology at the main hospital, who will be starting in the next month or so, Saul Priebus, internal medicine, Bordeaux, and then reappointments, Dr. Brian Fisher in vascular surgery, and Dr. Michael Gunn in obstetrics and gynecology. All were recommended for appointments to the medical staff.
Any questions? And that committee report will serve as a motion. Do I hear a second to approve these appointments to the medical staff? Any discussion? All in favor? Aye. All opposed? Thank you. Quality report, Ms. Denson.
Good afternoon. I'll be providing the quality report today. I want to start with an introduction of 2 new members of the quality department. We have had Benita Ordang. She's joined us 2 weeks ago. She's our new RN clinical risk manager and patient safety officer. And this week we had the privilege of having Tracy Bynum join us. He's our new infection preventionist. So neither one of them are here today, but please, if you do run into them in the hallway or see them, I would like to just welcome them to our organization. On to the quality report. I'd like to start with the quality dashboard, which is in your packet. This dashboard houses all of the relevant information and metrics that are publicly reported to Leapfrog and CMS. The relevance of this information is to ensure that we as an organization are providing high quality of care. The purpose of the dashboard is to provide a global overview of performance and ensure that we're doing performance improvements. Performance improvement is occurring, and we're reducing risk and improving outcomes. The benchmarks that are on the dashboard are national benchmarks that are set by CMS. As we review the dashboard, which I believe is not up on the screen, I think it is in your packet, in your packet though. Under the first goal is our safety of care. We did meet our first goal of falls with injury was met at 0% at greater than 365 days since our last event. Our second goal of hand hygiene was not met at 90%, and for both January and February. Now, I do want to point out that the hand hygiene information, it's important to note that the dashboard represents adherence scores, not which measure the percentage of times that hand hygiene is performed by healthcare workers. It does not measure what is not in the report is our observation score, which is the score, when our observation score for both February and January were 100%. This is a score that Leapfrog recommends and recognizes. I've talked with Felicia, and we're going to start adding that into the quality report. It'll be we'll add a column so that we can see that metric. Moving on to the barcode medication administration rate goal. This was not met at 92%, but it has increased over the past 2 months. We have implemented interventions that should help us meet our goal, which is 95%. The first implementation was to enhance our Wi-Fi, which has been completed so that we can have connectivity. Our second issue was the medication barcodes not scanning. This has been escalated to pharmacy, and pharmacy is monitoring the process to ensure that all items are being scanned and ensure that mobile devices are available to the staff at all times. As we move on to the quality of care, healthcare-acquired infections goals were met and remain at 0% for events greater than 200 days through the end of February 2025. This continues to support us having good outcomes for CMS reporting for value-based purchasing and maintaining our Leapfrog score. Our third goal of timely and effective care, this data is pending due to Cerner quality reports pending implementation and validation. Our fourth goal regarding patient-centered, we have changed the patient satisfaction survey results to be reported quarterly rather than monthly, and this was to increase our denominator to ensure comparative analysis and trending data is accurate. We should be able, our next report out will be in May of this year. Our fifth goal of culture of safety, I want to let you guys know the staff engagement survey response rate updates have been deferred until we have our patient safety survey, which will take place in July. Our final goal of regulatory, no surveys took place, so we have nothing to report. That's all I have for the quality report.
What is the problem in getting cesarean birth data?
Cesarean birth data? Felicia, can you answer that?
And I guess sepsis data too.
The sepsis data is an issue with Cerner, with the validation data within Cerner. We will have that information, I believe, in July.
It'll be either June or July. Anytime an organization undergoes a major medical record change like we did, we have to validate reports. And normally it takes at least 1 quarter, 3 consecutive months, for us to allow charting to kind of standardize. Mm-hmm. And then Cerner has standard reports that are built out that came with the platform that we ordered. But the problem is that every organization does not chart the same. So we're in the process now of validating charting compared to the data that's coming into the reports to make sure that it's reconciled. A lot of that information is based on coding too as well. And our coding team is working through to make sure that we're coding appropriately, billing, things of that nature. Both the C-section metric that deals with elective deliveries as well as sepsis are tied to that. And it's not uncommon. I know it's very frustrating because it's very frustrating for our department. But one of the things that we have been doing, we have a manual birth book as an organization. We still keep it. It's a ginormous book that we're following through by the Maternal Infant Child Committee, where if there are issues or trends where we see that there are a lot more C-sections than compared to the past, we're able to act on it. But we can't trend because we don't have a denominator because of the report.
I mean, if you have a manual birth book, that should give you a C-section incidence and total birth.
Yes, but with that metric, there's some other they call them risk indicators that come into that score that we can't track or trend right now. It's more complicated than just the total number of C-sections compared to deliveries, because CMS requires that we do have to risk stratify, and some of those do fall out.
Other questions for Ms. Rogers?
Quick question. We see the month-over-month performance, but, you know, several of us have been here more than a couple months. I've seen the trends and some of this data back in 2024, 2023. Is there an appropriate way to showcase this data that would be a more annual trend line rather than just a month-over-month is the first question. And then two, the action items around, you know, cleanliness and quietness of the hospital, responsiveness of staff, those types of things. You addressed when we're receiving the data. I guess I'd like you to address the how. How we're going to fix it.
Oh, okay.
Yeah.
I know that our patient, that Sherry Oliveras and Tori Tate have put together action plans to increase the number of responses that we're getting from our surveys.
And might I add too, a lot of what we're dealing with is that we don't have a very good return rate on surveys, and that's one of the reasons why we moved to quarterly reporting, because we had 1 month, for instance, I think it was back in January, where that was 3 surveys.
3 surveys.
And we didn't feel that it was fair to evaluate the organization and how we perform there based upon 3 surveys that were returned. So our goal is to try to at least, like I said, Sherry and Tori and their team are now trying to work through making sure we're more intentional, like in discharge planning, to talk about the HCAP survey, to encourage patients to return it, try to get our denominator up so we can do a fair comparison of how we're truly performing. And then hopefully with the quarterly, we'll have a decent sample size to truly track and trend. And then as that denominator increases, we'll move back to monthly.
Yeah, we're working towards to make sure that the data is statistically relevant.
I have a
Dr.
question.
Hudson?
Yes, in regards to the number one goal for safety and care, you mentioned, like for hand hygiene, for example, that there's a 100% observation rate. So where is the discrepancy? Is there a lack of consistent charting that hand hygiene has occurred? Or why is there a discrepancy between actual and observation?
Oh, the adherence is the adherence is a percentage of how many times people perform it correctly. Observation is just that did we meet our goals of observing the number of times?
Okay. And how is this captured? Like, how is this captured? Is it in LEAP? Is it electronically? That no one's standing outside doors watching people, you know, scrub in, scrub out. So I'm just curious how.
I could explain that process. We actually have all of our directors for the organization are assigned units to go and observe. And so they have a quota that they have to meet every single month that we track, and we hold them accountable to it as well. And it goes into an application that we use to monitor the number of observations per department, because Leapfrog requires, depending upon your census, a certain number of observations has to take place. And that's what Jana was referring to, that we have consistently met that goal to have the established minimum number of observations, but we also too monitor compliance to see how compliant we are with hand hygiene.
And that's for our own goals, to make sure that we're addressing any issues, we're recognizing and addressing any issues in hand hygiene. But again, Leapfrog does measure the observation, so we'll make sure that gets added to the report for next month.
That's helpful. I guess as we sit here, we want to be a support and help strategize ways that we can affect these numbers in a positive way. And so I think sometimes it's helpful to have this extra information. Not that you guys aren't on top of it. It's kind of like, is there a camera? Like, how do you know? So that's helpful.
There is technology out there, so if the organization is ever interested, I'm putting a plug, where you can do like digital monitoring via Wi-Fi. It's very complicated, though. I've tried it at some organizations. It works sometimes it doesn't. But it seems like what we have now is working pretty well.
Okay. Because it also sounds like Wi-Fi may be an issue with the barcode scan. So
We have enhanced the Wi-Fi.
okay. Thank you.
Yes, sir.
Mr. Chairman, I appreciate what you said about the numbers on the patient-centered and that we're working to get more responses. I understand that. And I may be beating a dead horse because I know we discussed this at the last meeting, but it strikes me that these benchmark numbers, I don't get why they're so low. I mean, these are about patients, and those numbers should be, the goals ought to be 100%. Why are they only 68, 72, and 74? And I understood there was some explanation that there was some national setting of that. I don't care about what the national goal is.
Okay.
I care about what our goal is. Why can't we up that number, those numbers?
We can revisit.
We
can
can certainly revisit. The only reason why we put that goal on there is because, in all honesty, we're trying to attain first what the national average is to make sure that we're getting the maximum benefit, not only from a value-based purchasing standpoint, but from leapfrog. Then as we move the needle closer to that national average, we will increase above the national average. It's very similar to, if you notice with the healthcare acquired infections under quality of care. The national average for HAIs is not 0, but because we as the organization have gone many, many months without an event, we chose to up the ante and make that goal 0. So as we move towards meeting the national average, certainly that goal will get above the national average as we continue to progress towards it. It's just right now we want to choose something that is attainable and then work towards increasing it after then.
I'd question that, but I understand your thinking process.
We're trying to be realistic, but we understand that, no, we don't want to say that 60% is good enough. No. We want to be 100.
And the only thing I would say was with regard to that same reporting goal 4 is I don't know that changing to quarterly, changing the way we measure something is the right answer. To me, we need to work really hard to get the number of surveys back. So modifying, you know, my mother used to tell me, you know, don't let your, whatever, change your religion to match your lifestyle. What I feel like, that was in college too, by the way, for the record. I just said that in camera. Yeah, I did. Hey, Mom. But sorry about that. The point is saying, I don't know that we need to move to quarterly just because we can't get the numbers. To me, we need to fix the problem, which is let's get the numbers up, right? So when we're looking at our processes, why don't we try to figure out, instead of saying, oh, well, so sorry, we only got 3. And guess what? We're 0 for 3, right? Let's go get the numbers. Let's figure out the best process. And you know what? It may lag a little bit until we get the process in place, but I think the accountability needs to lie there, not in, to me, the manipulation of the way we look at the data.
I absolutely agree, Ms. Smith, and I think what we could do, if you would like, next board meeting, we can bring the plan that the performance committee has put together and present that. That would help.
Thank you.
I'd just like to add that maybe, and I'm sure you've already thought about this and whatever, but it just kind of randomly poll other hospitals in terms of their campaigns in getting data, whether it's staff or patient or whatever, because I do know that there's some real creative ways in grabbing folks before they leave the building.
Absolutely.
In order to complete, you know, the surveys and things of that nature.
Absolutely. We'll take that under consideration. Our performance improvement person is here, so I'm sure she's listening to everything that's being said.
Any further questions about quality? And the ideas brought to me tonight, the quality committee would be very interested in having a board member to attend meetings, and that's very consistent with my goal for the board to have everybody on the board participating somewhere, and I think having a clinical person with experience with quality on this committee would be terrific. And since I've just become aware of this request, I'm going to ask Dr. Hudson to consider, after looking at their schedule and your schedule, attending the quality committee meetings.
Yes, and we've had these discussions before. I think it was a conflict in the scheduling. It's some Tuesday of the month, second Tuesday of the month, and I have another national meeting obligation during that time. So if I didn't want to, rearrange your standing meeting, but if we could make some alterations to that date.
Absolutely. We're willing, we can move the meeting around, and it is a virtual meeting if that helps at all.
Helps,
as well.
yes. Thank you.
Okay. I'll take that as a tentative yes. Thank you. And I would entertain a motion to approve the quality report. Any discussion? All in favor? Aye. Thank you. That does bring us to financial report. Ms. Smith?
All right, we had an opportunity to discuss the January and February finance reports. So with that, I will have Dr. Blackledge and Keith Moran review those.
Good afternoon. Thank you. So what we'll talk a little bit about is our January, February financial performance. Keith will speak to our board about that piece, and I'll come back and talk a little bit about what we have been doing over the last 30 days and what our intentions are for the forward 30 days. Thank you.
We would like somebody from the board and finance to come over and help us too. So do some debits and credits. Yeah, Christy, yeah, that'd be great. All right. So you notice we got January and February financials, right? It's month of March, and that's amazing that we have last month's financials. So
I pointed out in an earlier meeting that in my 3.5 years, that's never happened before. So thank you very much for that. We look forward to having it happen every month.
Oh, yes. And now that I know the 10th is the due date for next month, that's we're going to make it some way, somehow. So the January financials, I'm just going to do a high level. So let's look at the statistics for the month. And I'm going to just go with the average daily census for the month was 28.9 compared to a budget of 28 and compared to the prior month of 25.8. And the prior year was 31.3, so we're a little bit down from a year ago. Look at our emergency room visits were 2254 for the month compared to a budget of 2335. Compared to the prior month of 2324, so we're close. We're running close. The prior year we're right at it at 2299. So our clinic visits we had 4,007. In January compared to a budget of 3524. And also the prior year we're up from 3189 and then we're up year to date. We're actually down year to date to 31,000 from 36,000 for the budget. Our income statement for the month, it's not so exciting. We had a loss of net income of $2.2 million compared to a budget of $189,000. So we were down $2 million for the month. Bad thing is we had our inpatient revenue slightly down to 6.3 million from 7.8 of budget, but to the prior month we were down from 7.24 to the 6.3. Prior year, we were at 6.8 at that time. Our outpatient revenue was down 3.8 million from budget, but it was a little bit higher than the previous month, about almost right on, and it was higher from a year ago. So that's very good.
I'm sorry, just so I can, what we're looking at month ending February 28th?
We're doing January. Oh, sorry.
Yeah, the numbers that are on the screen are not matching the numbers you're saying.
Yeah. So I just started with January. Is that okay?
Okay, sorry. I was trying to follow, but now, okay, let me flip back. All right, sorry, go ahead.
It's okay. I'm sorry that was a misunderstanding there. So January, year to date, unfortunately, we were at 11.5 million year-to-date for actual compared to a budget of positive of 6.3. So we were down for January at $17.9 million. We have the same type of variances for the month. We have salary expense for over budget, contract labor, physician services, and other expenses. So I'm going to go on to February now. So the February average daily census was 46.4 compared to a budget of 31. And compared to the previous year, the previous month of 28.9 compared to the previous year of 30.2. So we did very well on the average daily census for the month of February. Our clinic visits were 4,321 compared to budget of 3,524 and to the prior year of 4,334. And year-to-date number on we found out on the budget is 1 month off, so it's at the actual year-to-date is correct, is 35.3 compared to a budget of supposed to be 31,000. It's the budget clinic visits. It's off by about 3,200 visits. The case mix index for the hospital was 1.14 for the month compared to a budget of 1.31. But our Medicare case mix was 1.56 to a budget of 1.42. And it's pretty much on schedule with the previous month. It's a little bit down from the prior year of 1.69. So our financials for the month of February. We had, for the month of February, we lost $4.4 million for the month compared to a budget of positive $397. A bright light in February is our inpatient revenue was up $1 million over budget, and it's up $2 million over the prior month, and up $1 million from the previous year. Our net patient revenue was a little bit below the budget by $780,000, down to $4,588,000. Our expenses for the month was $4.9 million versus a budget of $12.1. So the variance there is still the same type of variances: salary expense, contract labor, contract services, physician services. And that's got a lot to do with some of the new clinics that we've put in place that just hadn't up making money yet. Contributing as much as what we projected. So,
can I ask you a question about that point in particular?
Sure.
So the budgeted year-to-date outpatient revenue budgeted to be $160 million, more or less. We are at actual $140 million, so we're $20 million less than our expectation.
Yes.
But when I look at the budgeted med-surg clinic visits, for example, we have like 25% more med-surg clinic visits than we budgeted for. We budgeted 28,000 visits, and we're at 35,000 visits. The only sort of census kind of budget where we seem to be off significantly is the cardiac cath lab. We're off by, like, we had budgeted 541, actual 113. So I guess my big picture question is, why is it that we have so many more med-surg, which I take it to be roughly equivalent to outpatient, or let me just ask that first. Am I reading that correctly?
Oh, yes, you're reading that correctly.
So we're way above what we thought we would have for med-surg patients, but we're significantly behind in revenue. I don't understand. There's a disconnect there that would be helpful to understand.
Okay. Yeah, there is a disconnect there because we missed the revenue per patient revenue is what it is, or per visit revenue. When the budget was done at that time, they had overestimated what they thought we would be getting. And that's why because it's an educated guess at that time. So we missed that educated guess.
So more
'Cause some of these are new clinics.
more uninsured patients.
No, it's just the actual gross revenue is what we're talking about. Yeah.
Well, the cath lab will impact, but if you have
Yeah.
more patients than expected, less revenue than expected,
Yeah.
why is that? You're either your case mix is off, or the patients are non-paying patients.
So what we did was, I believe at the time, is we estimated that we'd have the cath lab. Okay, so we missed the cath lab revenue, and we missed some of the other just basic revenue as far as what we thought utilization would be by service. So that's really the reason that we're under budget is because we were probably over aggressive in our revenue and thought we'd be in a different place at this time. Does that make sense?
Not exactly. It's because we're 7,000 people more outpatient than we had budgeted. And I understand that what you're saying is we're $20 million less in revenue from that. But if we have 7,000 people more than we thought, we had budgeted 35,000 people come through. You're saying we missed the per patient revenue we thought we were going to get. I'd kind of like to get behind that a little bit. Like that is a big miss.
We didn't estimate the payer mix right.
Correct. The payer mix, there's something that, and just so that going forward we have, because we're about to go into a budgeting season, and like it's really important to understand why is it that we have so many more people outpatient and less revenue. We got to fix that so that we're not in this same way behind budget next year this time.
I
So
believe
you are
that
correct. Can I?
I'm sorry.
Go ahead.
That the budgeted number that's stated here of 28,000 is actually incorrect. Is that right?
Yeah, that's actually 31.
And he said it's 31. I still don't understand it because the year-to-date for January was 36,000, so that one was also incorrect. So both numbers for the budgeted number of med-surg are incorrect for January and February.
The clinic visits for year-to-date budget are incorrect. They're off by at least 1 month. So we budgeted more visits, but we didn't meet that visit.
So if I can add a data piece, I want to go back to the $20 million piece that we were talking about from the outpatient. So part of that is you have to look at the cath lab, and I don't have that number right in front of me, but I do believe it's $2 million per month that was budgeted for cath lab, and we can validate that number. And so if we're sitting and looking at February, that's 7 months, so 7 times 2. I'm just giving you a good portion of what that calculation is and how it impacts that variance in that category. Now, when we look at the clinic visits, I'm kind of separating the two. Clinic revenue obviously rolls up to the outpatient piece of it, but I'm giving you what is contributing to that variance, that $20 million variance at a point in time, which was month in February. And I just wanted to come up here and step up and share that piece of it to offer some part of the contributing impact.
Makes a lot of sense that the cath lab would generate significant revenue and not having that. So then that goes to the question that I've asked a couple of times, and I keep hearing in meetings, we need the cardiologist, and we need to get the actual infrastructure, the lab itself. But I keep hearing it's almost ready, it's almost done. We're going to hire a cardiologist, but boy, it sure seems like that's got to be a priority because it seems we would be in a much better budgetary position if we were doing cath lab procedures.
You have no argument from me,
Okay.
and I know we have board support that are helping us with some of those conversations at present. No argument from me there. You are
we are aligned on that piece of it.
So we have a new cardiologist coming next week, and a second one coming the 1st of July. Now, neither one of these cardiologists are interventional, so they're not going to be doing procedures, but they will be increasing the clinic and patient base of people who need procedures. And we are in contact with another organization to bring in interventional cardiologists. My understanding is the cath lab actually is ready now.
Yes, it's
And
ready.
We just
need a doctor.
folks to doing procedures. We are outsourcing now, and we are beginning negotiations to restore a relationship that we had.
So that won't be a part of the hiring freeze, right? Securing cardiologists. I'm saying that I know you just stated the months, but sometimes you get the paperwork going and then that time comes and you say, "Hope, we have a hiring freeze. We can no longer proceed with onboarding." So I'm just putting that out there that we talked about that in finance, that there will potentially be a hiring freeze. I just want to ensure that the cath lab won't be adversely affected.
Yes, ma'am. Can I clarify the hiring freeze? So when we say hiring freeze, we are looking across the organization and determining, is that position truly needed? For instance, one of the things you'll hear about when I get ready to do my audit report, I'll use valet services as an example. To replace that vendor contract, we have to hire valet drivers. And so the hiring freeze is really designed so that we're just not, haphazardly hiring or filling positions, reevaluating our workforce, seeing can we reorganize some things prior to bringing that position in. And so when we say hiring freeze, it's not an end-all be-all, because we will need to recruit for certain positions in the house. So I do want to clarify that for this team. Thank you.
One of the things I've spoken with some of the ELT members about as well is specific to the contracts. As an example, with on-call contracts and cardiology specifically, we got pretty deep in some of those contracts. And I guess one lessons learned, right, which is if they build it, they will come mentality. Like, we want to make sure that we are staffed appropriately when our labs and facilities go on point, right? So there's no reason to have a lab if it's not being used for months and months and months. So that's the first point. Secondly, with regard to the contracts, as we've evaluated, for instance, on-call contracts with our cardiologist, and when we had a change in the cardiology arrangement, I don't know how many months ago or so that was, that changed the dynamic of that situation. And now we have gone back, looked at that contract, reduced that rate to the median rate, and then have other people coming in, so those on-call contracts won't be at the kind of a grossed up pay that they have been. So let me just show you from my perspective, in digging in some of this is in the finance aspect. It's these are long-term, deep challenges where they're being uncovered bit by bit, but I have full faith and confidence in the team that they're doing the work and uncovering these and renegotiating contracts and creating processes by which these contracts will be to the betterment of the organization, and specifically uncover areas where, for instance, we're paying above a medium rate of $700 per call that we shouldn't be paying. So understand that it does take time. These are coming to light, and we're doing the work. The ELT team under Dr. Elders is doing the work. So I want to, at least my part of that and the research that I've done, to give you the confidence that is happening. We can't change what has happened, but these are things moving forward that we're looking at in very deep detail with every physician's contract going forward.
One thing that I would suggest as we go forward with a budget is that it's going to be pretty easy to estimate probably the number of visits that we may have for med-surg, but we need a more realistic number of what the income would be generated from that than what we had this past year. We now have, I don't think that our payer mix is going to change, so we should be able to estimate it and get closer to budget.
Yeah, we will definitely count on that to do that, so. And by the cath lab, we're 360 visits under year-to-date budget, which is several $1 million. So another chart that I put in here is coming up, and I like pies, so I thought y'all would like to see how our expenses was broken down. So it really puts it visual, how much we spend on employees and benefits and contract labor. So the center is the budget and the outer is the actual. Okay. Also, I'd like to go over the sources and uses report, cash report.
Can I ask one question?
Yeah.
I kind of touched on this. And when we talk about contract labor, some of that is traveling nurses. Some of that is emergency room providers and hospitalists, people that park the cars.
Yes. Yeah, that is correct.
All of those come under contract labor.
Yes. If they actually work hours, we have those as contract labor. The hospitalists, I'll have to check on to verify that. I think it's under, physician services, so.
And the emergency physicians also, are under physician services.
It probably is physician service. I think is that Epic?
I guess one thing it would be good to see, it would be nice to know what the real makeup is of contract labor.
Right. Well, I can show you that.
Okay.
I don't have it with me right now, but we have it. So we can have it next meeting for you. One thing I'd like to talk to you about on the sources of uses and cash report, which is right here. So you'll see a big number in the center, 22 million and 21 million. So just to let that shine out, that's just our Cerner implementation. So we booked it as a lease. So just to let you know, so you don't have any questions about that. So that's a GASB thing. So, and this also report shows you how much cash we used during the year, and also this whole year. So you can see that our bottom line cash as of February 20th is $3,395,000.
So tell us what the implication is. That has been, so our cash position over the course of the fiscal year is diminished by about $10 million.
Well, yes, that is correct.
Right. So that's, we had 13 million begin in July 2024. We're now cash position at the end of February, 3.3 million. Again, like my field is not accounting, but those numbers seem to be cause for concern. Are those going to improve? If we keep deteriorating the way we are, our cash position will be zero at some point, and that seems bad.
So what we're doing is implementing steps to avoid that problem.
Okay,
So
what's that?
Dr. Blackledge is going to discuss those steps that we're doing.
Okay, sorry, I jumped the gun there.
No, it's okay. It's okay. You keep me on my toes. Also, we will look at the balance sheet. And on the balance sheet, there's a new item on it. It also matches the cash number, the numbers tie. And you'll see we have other current liabilities down here. You'll look at went up, and that has to do with the Cerner implementation where we capitalize that project. So any other questions?
Okay, thank you. Dr. Blackledge?
Good afternoon again. I do want to share by talking about our cost reduction strategies. So over the last 30 days, spending more time in this space about how do we shift gears, how do we move forward, how do we make necessary changes, right, to get in the right position. So 3 things continue to resonate. You guys saw this last month. It was economics, accountability, and culture. Economics in the way of how we make decisions and allocate resources. Accountability about owning it, owning our current situation, owning how we move forward, owning how we communicate those things to our board, which is why I did this in the Finance Committee and here again. And then culture, lastly, is really the way in which we work. It's like the way in which we execute and get things done for the organization. So on behalf of the organization, how do we get things done? If I move to the next slide, what we have before us is our budget assumptions for FY26. And this is just brief because we went through this last month and had it approved last month. I just want to point out a couple of things. Our patient and other revenues are about $164 million. One other number that I will give you right now is our expense. So we've got $164 million for patient and other revenues, and we have $161 for our expenses. That means that we have to shift gears as it relates to our expenses, what we just spoke about a few minutes ago, before we jump into the new budget year, right? Because we want to see some things different. So what that gives us is about 95% of our total expenses as we look at our revenue. And so that's right now we're running about 107%, 108%. So we're trying to get into the right space as an organization. I think that's it I want to share on that slide. In order to do that, we're going to need to reduce by about $8 million from our current spend. So when we think about our cost reduction strategies, right now we're looking at 4. Salary expense, and we talked a little bit about a hiring freeze. Where patient care is, where certain areas are, we are going to fill positions, replacement positions. However, when it comes to new positions, that would be a pause. Even on existing positions, there will be a temporary pause because we have to evaluate each role. Our goal is to reduce costs and to improve our financial stability. So that is one mechanism that we're putting into place. Second is a position control governance. So one of the things as a hospital, we have to have oversight of team members onboarding, offboarding. What does that look like? Are you contract labor? Are you on the hospital's payroll? How do you look at that from a global standpoint, a total I'm about to say U.S., but a total NGH standpoint? Today, we probably have 8, 9 different pods, and it's looking, if any one of us played the mole whacker, you have to look at all of them. And so we're trying to pull that into a position control governance, and so we can have oversight of that contract. And I don't have a dollar value for that. So it is TBD today, to be determined. And that's going to be ongoing too, about the savings from that pot. Contract labor expense, we have about $5 million worth of savings coming out of this pot, and that is through contract eliminations. We have met, we have term dates, we've executed on probably 90% of those. So just so you know, and more importantly, these are non-clinical items. We have not began the clinical review, which will be very different. And it'll be very different because we have to look at how we offboard, particularly travelers, and to ensure that we have the right salary infrastructure for clinicians and other things. So we've got to look at some of the nursing salary pools. Thirdly is contract services. And so through elimination, we've gathered about $1.2 million. So we see that as a reduction strategy for probably about 6 contracts in that population. I want to pause to say for the ones where we anticipate terming or eliminating, we've communicated those dollars for the last final month will have to flow through the accounts payable system and be paid, right? So we'll look at seeing the benefit of that in June, July. Lastly is a clinic change in operations. We have a clinic, namely called Bordeaux. In that Bordeaux clinic arena, we have an urgent care area. That urgent care area We will be looking at it, evaluating it for closure. Just the urgent care portion of that area. We don't see many patients, but this is a situation where we have high expense, low patient volume, right? And it's what I call shrink to grow. You'll hear me talk about that in a minute. Next slide. All right, contract labor. So I want to pause right here and talk about the contract labor. We started with the budget for FY26 that was shared with you in our last meeting. What you see in the red bracket is the contract labor piece. And so our projection and the way we are running today, we're at 15.8 million. And so our goal is we need to position ourselves to spend $11 million. So in order for us to move from our current position to the future position, the actions that we just spoke about and saw on the slide, those are the actions that we're taking to get us there. So that's the contract labor piece, $5 million annually. And then contract services, about 1.2, and then the Bordeaux urgent care under what we call performance evaluation to look at that piece of it. And then this last slide, I'll talk a little.
Before you move ahead,
Yep.
regarding Bordeaux and
Yes.
urgent care.
Yes.
So I assume that when we decided to have urgent care facilities, it was in anticipation because of a lack of urgent care facilities in the community. Is that fair?
Likely so. I don't have the total history on that. I have the current state.
So to what extent do we feel like the community is aware that urgent care is available at Bordeaux?
Right, and that's a good question, because what we do not know is what percent that the community is aware, but what we do know, and let me flip to the next slide, and I'll catch up with your question. You can tag in again. So here in the bottom, one of the things that we must do is look at it from a strategic redirection, and that time spent under the strategic redirection will help us understand the answer to that question. It won't change likely our intent to bring that part of our business, the urgent care, to closure. And the reason is, if that is the case that the community isn't aware, then we need totally different marketing campaigns. We need a lot of something different. And there's not really a benefit in keeping it open if we are seeing 2 patients on a Saturday and Sunday. So it's open on Saturdays and Sundays, and if we're seeing a low volume of patients, that's not really probably a good, solid strategy decision for us to execute on. But that is part of the strategic
Was there
redirection
urgent care at
conversation.
other times during the week or just Saturday and Sunday?
I think just Saturday and Sunday, if somebody, that's correct,
I
that's
can
correct.
speak to that. Yeah, just
Yep.
Saturday and Sunday, Dr.
Correct.
Miller. Now, on Monday through Friday, there are walk-in appointments.
Correct.
So you can walk in Bordeaux and be seen by a clinician. And so that was one of the strategies to address that. The urgent care was put on the table because we staff an emergency room physician on Saturday and Sunday. You have a radiology technician there that can perform x-rays. You have a clinical person that can help assist the doctor, as well as somebody that registers. Bordeaux Clinic is right down the street from us here. And so our thought process in doing that is redirecting those people Saturday and Sunday to our emergency department where we have availability. We have the urgent care space in the emergency department. So as Dr. Blackledge reiterated, it's more of a redirection of services there so that we can give that clinic a chance without that expense. Thank you.
Thank you, Dr. Elders, for adding that piece. So for us, that strategic redirection, number one, it gets us at the table. Number two, we have a written plan that walks. So if you close the clinic down, you just don't close the door. So there are steps that we must take, right? And we must memorialize the thought process, the activities, the data, everything that we have, we must memorialize that. So that's the operational and financial review. We'll document it, make the decision, and then the communication plan goes to our partners, to the board, and any what I would call post-closure activities. So those are the things. So I'll work my way up in this slide. I hope that helped answer that question. before I move forward, anything else? All right. So if I go back to the top of this slide, then these 4 items we will have the benefit of about 6.2 million. When we look at these 4, we have 2 items that are to be determined. We must look at the salaries from a hiring freeze standpoint, because I really want to be clear. People get work completed. They do work, and that work needs to be timely, and everyone has to own that. So we need people to do the work. We're not looking to do anything other than have people do the work. Our task is making sure we have the right people in the right places at the right time to get the work done. And that's the salary piece. Then contract labor, that's 5 million, and then contract services, 1.2. And then the clinic change in operations is reviewing the Bordeaux urgent care only, and that's to be determined. So those 2 buckets are to be determined, but that's our current piece. And then lastly is the position control governance. And I've shared, and I could go share a little bit, but that's workforce planning and forecasting. I mean, part of what we are challenged with, particularly myself in the role, is I have to have an understanding of team members onboarding, offboarding, what does that look like, understanding the difference between an FTE number that deals with productive hours versus a head count, because if you've got part-time people, that's a head count. So having that conversation, understanding that, and then the cost management piece, looking at the clinical versus non-clinical. We've spoken a little bit about that. And then putting this governance piece into place with implementation, and then ultimately we should just have oversight of it, because it will run and it will provide the right information and data that we need to make that pointed decision with some level of precision, confidence, and competence. And that's kind of where we've been over the last 30 days, and kind of where we're going over the next 30 days. And I'll be back next month with another update.
May I make one comment?
Sure.
First of all, I really appreciate the attention on this strategies, because it's absolutely necessary, and it's very comforting that you're giving this thought and have this plan in place. And as I think about big picture, the components of the plan, you're finding savings in contract labor, which makes sense because contract labor is the largest place where we're missing budget right now. Yep. You have a TBD for salaries, which makes sense because that's the second largest place that we're over, which is also close to $4 million.
$4 million.
So that's right. Now, as I look at the categories in our budget, the 3rd largest deviation from budget expenses is our other expenses.
Correct.
Which is about $3.3 million
3.3.
off. So I guess it's a request for you, as we're thinking about the categories, that other expenses is kind of a strange amalgamation of expenses, be that as it may, but that does seem like a place that merits this same kind of inquiry, which is, why are we $3.3 million off budget, and are there cost reduction strategies in that area that we could add to these sort of bullet points of categories? As single board member, I'd be very interested to see whether this analysis applied to that category could yield some cost reduction as well.
All right. Thank you for your question. Number one, I would answer it this way in 2 pieces. Our budget is our budget right now, right? That's number one. So when you think about, that's not going to change. This is the budget that I walked into, right? Second part of that, I believe I sent you a file board meeting before last with all of the detail of the other categories. What we have listed in that category literally keeps the lights on, pays for the parking garage, pays rent, pays, is all necessities we need to run a business. So our first thought and the best use of our time is always looking at where we are going to get the biggest benefit for our time. So contract labor, working with the salary piece, those components. We will come back to the other services piece or other expenses piece, but recognizing that when we looked at that initially, is all the things that need to stay in place. Now, whether that dollar amount was set right and that history pulling forward, we will definitely do that, and we are. But it's going to take a little bit of time, more than the next probably 30 days.
Makes sense that utilities, rent, you're not going to have cost savings. Those are contractual obligations. Maybe the point for the next budget cycle is from a board perspective, it would be more helpful to have that categorized in the budget as utilities or occupancy or, right?
You know
Yeah,
what,
because other doesn't help. If you say we have occupancy and utility expenses and those sorts of things, of course, like that's not a place for savings. So it's hard from a board perspective to see $3 million over in other, but when you tell me it's rent, well, okay, it'd be easier to break that out so we understand that.
You are absolutely correct. And the note I just wrote for myself is common language. One of the things that I am intentional about doing when I speak to people is using common language, right? So we've got this listed as other expenses, but I'll look into it and see what we can do to kind of modify that because it should be common language and to share that. So I appreciate that feedback. Any
Mr.
other
Leslie.
questions for me?
Yeah, thank you, Mr. Chairman. This is a solid initiative. And it's an overdue initiative. And congratulations to you and the team and Dr. Elders. Let's stay on this because this has real merit, not just from a numbers perspective, but really from how we run this hospital in a more efficient manner. So again, thank you for that.
All right, I'll close with economics, accountability, and culture. That's it. Thank you all.
Thank you. I would entertain a motion for approval of the finance report. Oh, I'm
Wait.
sorry.
Sorry, we decided instead of doing an approval, we would do an informational at the Finance Committee, so we will pass the approval at this point since there's some changes, modifications that we were going to be making.
Okay. Thank you for that clarification. Under new business, first is CEO severance agreement and release. This is an agreement with Dr. Webb that has been negotiated by Metro Legal. It has been distributed. All the board members have had a chance to see it, but I would ask for our attorneys to explain the basics as well.
Thank you, Chair. Dr. Martin, I'm Wally Dietz, the law director. I personally negotiated this agreement. So I wanted to be here to answer any of your questions about it. I recognize that it is a lot of money we are talking about, but I want to give you a little bit of background on the negotiations and how we got to where we are here, where I am recommending, the law department is recommending that this board approve this severance agreement. Negotiations started with Dr. Webb's attorney back in the fall. Dr. Webb's attorney, Jason Holloman, called me. I did not initiate these discussions. Dr. Webb's attorney did. Jason Holloman called me and started making some claims against Metro, the hospital in particular. There were several components of his original claim. The original claim was over $1 million. Certain components of the claim I did not believe had any merit at all, so I removed those. The biggest single part of his claim was for an unfunded retirement benefit that he claims he was owed from the early years in his contract. The first 3 years of his contract, he did not have a supplemental retirement package on top of original compensation like he did in subsequent years. In the last 7 years, that piece of his compensation was a very generous part of his compensation. He believed that he was owed that. He believed the board promised that. He believed that subsequent boards promised to pay it when the board, when the hospital authority had the money to do it, that it was an obligation that was made in the early years and renewed by the board over a period of time. That was a claim that would have involved going back into the records, the minutes. We did some of that. It was less than clear, frankly, whether or not this was a valid claim, but we knew that there were board members from prior boards who would testify under oath that Dr. Webb was owed the money. That meant that we would be very unlikely to win the case on a motion to dismiss or on a motion for summary judgment. This case, if it was brought, it was almost certain that it was going to trial with an uncertain result. So that was the hand that the law department was dealt. And so we started negotiations. Those negotiations concluded in early December without coming to fruition. So there was nothing to present to this board. The negotiations accelerated. Looking back at the calendar, it was February 25th that the CEO Evaluation Committee made its recommendation to the board. Negotiations took off the following day. On February 26th, I was on the phone with Mr. Holloman most of the day and back and forth. And so we entered into an agreement in principle to pay the amount in the settlement agreement, which is $890,813.26. That's an odd number. The reason it's an odd number is that his accountant calculated the original benefit and then applied a 5% interest rate compounded annually. And the methodology was fair. And 5% is an interest or an estimate of lost value based on market value. If he had invested that money in the markets, 5% was a reasonable return. We verified that. And so that got the number from the principal amount was well over $300,000, but with the compounded interest, it came out to $890,000. So I did not think it was in Metro's best interest to agree to pay that unless we could obtain some concessions from Dr. Webb. As of Wednesday the 26th, it appeared very likely to me that this board would vote not to extend his contract beyond June 30. Based on the report coming out of the CEO Evaluation Committee, it looked much more likely than not that this board was not going to extend the contract. So that meant that this board, the hospital, and Metro was facing a four-month period of a lame duck CEO with hostilities flying potentially between the parties. It would have been very disruptive to everyone. And so I believed that it was in Metro's best interest to negotiate an early exit. And I agreed that Dr. Webb should have 2 weeks to wrap up his affairs, to say his goodbyes. It wasn't appropriate to say, here's a box, take the things out of your office. It wasn't that kind of situation. We weren't going to treat him that way. So Dr. Webb and the lawyers from Metro agreed that his last day would be March 14th. What I did not know is that he was going to jump ahead and send the letter that he sent within minutes after I sent an email to Jason confirming the basic elements of the deal. I believed it was there was real value in the fact that the hospital authority, and all of Metro could begin this transition 3.5 months earlier without all the discord. The second piece of value that we negotiated was to get a full and complete release from Dr. Webb of any claim arising under the contract or in any way related to his employment at the hospital. So we have a complete release. There should be no litigation from Dr. Webb on any matter relating to his employment going forward. I believed that also had value. And so, to me, this obviously is a judgment call. People may criticize the judgment. People may decide it's not in the best interest to move forward. I strongly believe it is. I believe that the concessions that Dr. Webb made in exchange for our agreement to pay the $890,000 have real value to Metro, over and above just the value of settling a lawsuit that would be contentious and uncertain in its outcome. So I believe this is in Metro's best interest. There is one point that has changed since the agreement was drafted, and there were some discussions earlier today. In Section 1, the payment of the $890,000 will not come from Nashville General Hospital. The original plan was to pay the claim as part of a supplemental appropriation from the Metro Council to get the hospital through June 30th. It was clear to me at the end of February that a supplemental appropriation was coming based on conversations I had with our finance director. She knew it was coming. I think a lot of people on this board knew that there was a need. So this was originally designed to be paid from the supplemental appropriation, which is in front of the council next Tuesday night. Instead, because the finance director last week suggested that it would be better to pay it out of Metro Finance's Judgment and Losses Fund, which is there to pay disputed claims, settlements of disputed claims, so that it does not have to run through a supplemental appropriation and the books of Nashville General. And so I am proposing that the amendment that the agreement you have in front of you be amended in Section 1 in the payment section to strike the letters NGH and insert the words the Judgment and Losses Fund of the Metropolitan Department of Finance, so that the one-time retirement payment comes from the Judgment and Losses Fund of the Metropolitan Department of Finance. It's not an obligation separately. It's not an obligation of Nashville General Hospital or the Hospital Authority. It will be paid as other disputed legal claims are paid out of the J&L Fund. So I'm asking you to approve this agreement with that oral amendment. I have just spoken while we were discussing finances and other matters. Jason Holloman, Dr. Webb's lawyer, has no objection to that amendment, so he's fine with it. His only concern was whether it would delay payment. It will not impact the timing of the payment at all. So Dr. Webb has agreed to that one change. That's the only amendment I have, and otherwise I'm here to answer your questions.
Any questions from the board? Mr. Esquivel?
First, I appreciate the very thorough explanation of how we got to this point. And just to clarify something that in reviewing the agreement is I don't see in the agreement and make sure I understand the significance of that. There is not, part of this agreement is that Dr. Webb is precluded from bringing any kind of claim, litigation, anything related to his employment. Is that right?
That is correct, Mr.
But there's not a reciprocal, prohibition on the hospital. So without prejudging any circumstance, there's nothing in this agreement that precludes the hospital authority, the hospital, if there is a dispute related to his employment, that the hospital may pursue that.
No. No Metro entity, not Metro is a metropolitan government, not the hospital authority, not the hospital itself. No Metro entity has released claims against Dr. Webb. Those claims will survive the execution of this severance agreement.
Thank you.
I would entertain a motion for approval of this agreement with the amendment as proposed.
Moved. Second.
Any discussion? All in favor, say aye, please.
Aye.
All opposed? Thank you, Mr. Dietz. Motion passes.
Thank you, Counselor.
And that allows us to move forward with the CEO search which I'd like to discuss briefly. I will tonight appoint a CEO search committee. In fact, I will do that now and then discuss any ideas that any of the board members have about how we would proceed. On the search committee, I'm appointing Mr. Escobar, Dr. Miller, Ms. Smith, Dr. Nettles, and Dr. Ensenura. And I would charge them, at least in the beginning, first of all, to meet promptly, hopefully starting the week of April 7, and to consider the development of a job description and get it posted, to make recommendations about whether to seek an interim CEO or not. I'll add that this top is spinning pretty smoothly right now, and we're excited and proud about the way Dr. Elders and her staff are conducting things. But we initially had talked about an interim CEO, so we'd like a recommendation from the committee in April about that, and to move on the process of selecting a search firm. I would also open the floor for other ideas that board members would have about how to proceed with the process. I also will say that we've received a number of inquiries and interest from a lot of people around the country, some prominent people with local experience, and we'll be sharing all of these, not just with the committee, but with all of the board. Most of them have already been shared. Some others have not been shared widely yet because of at the request of the individuals who have expressed interest. So this appointment of this committee does not require approval of the board as it is an ad hoc committee. But I would like to entertain comments from others about how we would direct this committee to go forward.
What's the process for engaging a search firm?
This is one of the first things that we need to do. There is a procurement department in Metro that we can go through. There are search firms that they have worked with. I am very interested in engaging a search firm with specific healthcare experience, and I've come up with a few names for that, which I've forwarded to Mr. Escobar. Did I say that I would ask you to chair the committee? Maybe I didn't say that.
No, I mean, that's a bait and switch sometimes. But no, I'm joking. I'd be honored and very pleased to chair. Thank you.
So that's to be worked out. We want a search firm that will come up with experienced healthcare professionals. Any other suggestions for the committee as they begin their work? I will be an ad hoc member of the committee as well. Okay. Thank you. The next item on the agenda is action items for the auditor's report. Dr. Elders, our acting manager.
All right, good afternoon again. In your packet, you have our action plan in response to the audit performed by the Metro Office of Internal Audit. First, I want to say we acknowledge the importance of accountability, and as an executive leadership team, we accept responsibility for the findings and have implemented the following. You have that corrective action plan in your packet. For allegation B, it was a substantiated allegation in regards to our valet services. Dr. Blackledge has sent a certified letter to City Valet on March 17th, identifying the overages that were supposed to be reimbursed to us with the date of April the 21st. With that also, we intend to bring valet in-house and recruit and retain our own valet drivers moving forward and terminate that contract as soon as we are able to do that. For allegation C, it was a substantiated allegation where the CEO excluded specific clinical and non-clinical contracts from the hospital authority board process. We have implemented multiple actions to address this. We have a new internal process for submitting contracts. It includes a new contract form with all of the elements that you spoke about in Finance Committee for greater transparency in that. There will be mandatory education for all leaders and managers submitting contracts. In addition, the executive leadership team will have a date to where contracts are due, and we will prioritize the ones that we feel need to come to the board first. I think originally those were just kind of passed off to Janet and put on the agenda. We will stop that process as well. There'll be a separate signage sheet that has been created by our compliance officer where you will have to have the signature authority of the CFO as well as the contract owner prior to anything coming to the board as well to ensure that we are in line with our budget and it's something that we can afford to process. Allegation D, which Ms. Donnell also spoke about for Dr. Billups, we canceled all of his patient appointments. He is no longer utilizing the space. As she stated, this is a clear Stark violation in which we will also self-report. And Christy, our compliance officer, is working on that as well. For allegation E, it was a substantiated allegation where contract signatures and dates were falsified. We agree with that finding, and we are in the process of looking at DocuSign or some kind of program that allows us to track signatures with time, date, IP, moving forward so that we can ensure that that doesn't happen again. With that, the details are outlined within your report, and I will answer any questions at this time.
Any questions for Dr. Elders? Mr. Escobar?
We heard the financial impact of self-reporting on Meharry. Do we know what the financial impact will be of our self-reporting on the Stark violation?
I don't believe we have one. Yeah, we don't have one. There was no exchange of funds from our end. It was just space and staff and things of that nature. Yes, sir.
I just want to note that you guys moved really quickly on this, and so I appreciate that. To be able to take the information, quickly turn that around and create processes, I just appreciate everybody who worked on this. I know it was a heavy lift. It was one that you prioritized, and so just from the board, we appreciate that work.
Thank you.
Don't think this requires approval, but I think we approve of what you're doing very much. Thank you. Next is ratification of the notice of termination of community health marketing contract. As you know, on February 28th, Community Health was sent a communication giving them notice of termination of their contract. Contract required 30 days notice, and so as of March 30th, the contract is terminated. Due consideration was given to this. Would have liked to have done this at a board meeting, but it would have cost us another month and of expense, and also in a relationship that just wasn't going to work anymore. There'd been concern of the board for some time about failure to produce and document sufficient tangible results to justify the expense of this arrangement. And there were comments made by Mr. Maynard that I think irreparably damaged the relationship with the Hospital Authority Board. And it was because of these things, in consultation with the legal department and the mayor's office, that I went ahead and moved on this, and was assured by the legal department I had the authority to do this. However, I would ask for any discussion about it, and would ask for ratification and approval of this termination, and open the floor for discussion now. Or a motion.
Move to
So
approve.
move.
Any discussion? All in favor? Aye, please. All opposed? Yes, sir. Okay, this gets us to the extensive contracts we have to approve or consider tonight, and they've been discussed thoroughly in committee before this, and Ms. Smith will give us a summary.
All right, so we'll move through these. We had an opportunity to discuss all of these in great detail. Additionally, when the agenda came out, I reached out to both Dr. Brown and Melanie Thomas and spent over an hour of their time, thank you very much, in discussing each of these. So I appreciate the work that's going in to create the process, looking at kind of systematizing it, as well as creating consistent and ongoing consistent visibility about the owners of the contract, the revenue, the exit strategies, the timely reporting, and the evaluation process that happens prior to the contracts coming to us. We do have two contracts, which we won't go into, that will be deferred, so that's Fujifilm and Treehouse. So with that, Dr. Brown, please jump in if you have any other comments to make, but being that we've gone a little longer, I'll try to summarize. Radon Medical Imaging is a contract that has come before us. It is a piece of equipment that has been refurbished, but has, the equipment that we have has broken about 8 months ago, and was generating about $250,000 in revenue. This piece of equipment has far exceeded its life, and so we were able to price both a new piece of equipment as well as the refurbished piece. And so the decision has been made to move forward and save us some money getting a refurbished piece. And that is the contract that is up for approval.
What is, this is a C-arm, right?
Yes.
Yeah, and what is RNF room? It's
Dr. Miller, that's a radiographic and fluoroscopy unit.
okay. So there's two dollar figures here. One for
Yes, sir.
And what's the one's for 240,000?
That's the radiographic fluoroscopy unit.
Okay.
And then the OEC is the C-arm for the OR.
So it's one fixed imaging and one CR.
Yes, sir. Mobile.
see. Okay.
Exactly.
All right. It's been recommended by the Finance Committee. Do I hear a second? Any discussion? All in favor? Aye. All opposed? That passes.
Second item is a practice resource network agreement, and this is simply a reporting mechanism by which we are required by the state to send information up. It is, there are 3 entities that do this, and they're all the same cost. So this is the one that was recommended by our ELT for us to continue with. So this validates our procedures and make sure that they're warranted at the state level.
The committee recommends approval. Do I hear a second? Any discussion? All in favor? Aye. All opposed? Thank you.
All right. So we will defer Treehouse Homes. Next up is the electronic registry system. So this is, again, a reporting mechanism by which we are required to send information up. This is a cancer registry service system, 3-year contract with auto renewal.
Any discussion? All in favor? Aye. All opposed?
All right. Next contract is Sophos. So this next few contracts are with Melanie Thomas. This is actually an antivirus software program. Other programs were priced as Palo Alto, but after looking at other vendors, this process seemed to be the best. Well, the process seemed to be the best to stay with the current system, as doing lots of changes in the technology world seemed to be cumbersome and timely with a lot of training involved. And so that being said, we decided to stay with the Sovos system.
Any discussion? All in favor? Aye. All opposed? Passes.
Next contract is the Presidio contract. The Presidio, and there's a couple different Presidio contracts. Presidio, the Cisco, and another Presidio contract. This specifically is a monitoring contract that allows a 24/7, 365 monitoring of the networks. And Ms. Thomas, is there any quick comments on this? You're our techie here.
Basically, you capture the biggest piece of it. It gives us 24/7, 365 coverage of our monitoring of our network. This is not something that we're able to do at that level. It also provides a next level of support for us beyond the expertise of our existing staff. And I have a highly certified staff. I mean, they get all of their certifications, so this is a need.
This will protect with email, Cerner, any.
So the Sophos contract was the antivirus for that. The network services protects our equipment.
And we did talk a little bit about the monitoring at the committee level, the monitoring systems comparative to actually a physical hire and or training up and receiving more certifications. And so I think, it looked as if there was about a 3x cost in trying to hire our own employees that would be at the same level of this specific monitoring system group personnel, if you will. So I think that's always a good question to ask, especially since it's an ongoing cost.
Discussion? All in favor? Aye.
Aye.
All opposed? No. That passes. Thank you.
Next is the Cisco contract, which I will let you give a quick blurb on.
Yeah, so that is for our multi-factor authentication. It provides an extra layer of identity authentication for users. So very much like if you're logging into your banking application and they send you a text for you to verify who you are, that's exactly what it does for us. That is a 36-month contract. This is something we didn't have when we had a security incident years ago that could have potentially prevented us from having that.
Discussion. All in favor? Aye.
Aye.
All opposed?
Last contract is again a Presidio contract. And just so you know, we did debate these hotly in our meeting. You're always welcome to attend those meetings. And again, I had individual calls with both Melanie and Dr. Brown to vet these, as well as even vetting them through Dr. Elders and Dr. Blackledge to understand the financial impacts. So I know we're moving through these quickly, but please understand we spent hours on this work and these contracts. So
yeah. This one is managed detection and response. So we have people from Presidio looking at our systems 24/7, and if they see something, they call us immediately and puts our team into action. And if they can respond and resolve and fix it before we even get to it, they do that as well. So this is definitely a need for us. Another layer of security for us.
Discussion?
Thank you, Dr. Miller.
All in favor? Aye. All opposed? No.
thank you.
Thank you, Ms. Smith. Brings us to Board Chair's report. This coming Tuesday, Metro Council will meet, and they'll be talking about the hospital in a couple of ways, and I think it's important for us to communicate. First of all, they'll be considering the settlement agreement that we just considered and has a strong recommendation of Metro Legal and now approved unanimously by us. They will also be considering a supplemental appropriation that has been proposed out of our Metro's auditor's office after extensive meeting with Dr. Elders and others, looking at our cash flow and the determination made that an additional $10 million would go a long way in helping us to get through this fiscal year. So I think that, you know, for some of the council members maybe that don't follow this very closely, these are two big numbers that they'll be questioning, and I think it would be really important for us to communicate with them about that. And finally,
Mr. Chairman, being unfamiliar with how council operates at these meetings regarding budgets, who represents us on those two discussions?
I believe that Janine, our auditor, will represent us.
Janine Reed is Director of Finance. And so since she has been working with, I know Derek and Wally in terms of drafting some of the required requests, in addition to the fact that Dr. Elders, Dr. Blackledge, and myself and Ms. Reed have been working and having regular meetings on this, working with and evaluating cash flow for Nashville General Hospital between now and the fiscal year in June 30th, and making sure that we understand the obligations and also looking at trying to get our accounts payable up to a more appropriate level. And so we have the opportunity to, again, move that side forward. So this has been a lot of work to get to this point. I will tell you, it is a hard ask for us to make. It's a hard ask, I know, for this board to make, but at the end of the day, it is where we are. And I think we have an excellent plan moving forward, but you will probably get some questions about it. You may get some flack at best about it, and but it's the right thing. It is where we are. It will put us in a better financial place. It will allow our vendors to be paid in a more reasonable time frame, which means they will be more apt to do business with us and provides us the goods and services that we need. And we can show them based on what our ELT has shown us how we will better manage our finances and be more fiscally responsible going forward. So this is a position that we are at.
I'm totally in line with you. All I was asking was who actually makes the presentation.
Sorry.
Okay, thank you. That's okay.
We have about a $60 million subsidy from Metro. How much of that have we gone through this fiscal year?
I think the subsidy is distributed monthly, so we've gone through 8 months of it. Correct?
Yeah, we've got approximately, I'd say about $8 million left. And we're getting 5.3 next week.
That's factored in.
Yeah.
It's factored in.
So we believe that with the $8 million left and $10 million, that'll get us through June 30th. That's what we need to do.
Dr. Elders, you want to answer that?
Sir, that's exactly what we're going to try to do.
Okay.
So, and I'll say try. That is, as you saw in Dr. Blackledge's presentation, that's why we're so committed to the cost strategies. And there'll be some other things that we'll be able to share along the way. Don't have all the detail today, but that is our plan, is to make it through June 30th with what we are appropriated. Yes, sir.
Did you have something, Wally?
Yes, Mr. Lesser, specifically, the supplemental budget resolution is an administration piece of legislation. It's sponsored by the mayor. Finance Director Janine Reed will be there to answer any questions at Budget and Finance Committee and also at the council meeting itself Tuesday night.
Anyway, I think it's important for the council members to hear from the board about these things. And the final thing, the supplemental appropriation, the settlement agreement, and also to hear about our need for capital. Historically, this hospital has gotten very little capital to keep things going. We got a generous allotment for this fiscal year of $7 million. The council does not ultimately decide on how much capital we get, but we need their support toward the mayor's office to keep this amount at least capital going. So with that in mind, any of you that have relationships with council members, contact them, but I have actually a letter drafted from the HAB that's in front of you and directed to Vice Mayor Henderson and all the members of Metro Council that will come out under my signature, but my preference is that all of you would sign it. So I'll have it right here. Please, before you leave, review it, and if you're willing, please sign the letter, and we'll did you give everybody a copy already? Okay, great. And speaking of communication, I'm meeting weekly with Dr. Elders at her invitation, which is quite different from what I'm used to. Ms. Smith is also meeting regularly with leadership team. Communication is at a very high level, and I appreciate the work of all of the team, particularly Dr. Elders and Blackledge. As you've heard, they've worked hard and fast at getting some answers and planning for the future for this pivotal transition that we're going through now. And for all the employees and medical staff, many of whom have reached out to us with measured anticipation and a look toward the future. They're looking toward us to make things happen, and I think that we could do that. But we've gotten a lot of encouraging words, and I appreciate that. But particularly what we've gotten from the leadership team. With that, I'll turn it over to Dr. Elder's report.
You know, I was very concerned about this period. I didn't know exactly how we were going to get through with it, but I am very much relieved by the approach that Dr. Elders has taken. I appreciate all that she's done to date, and I'm very confident that our leaders are doing what we need to keep this place where it needs to be and to advance to the future. So I thank you.
Thank you, Dr. Miller and Board, for all your kind words. I truly appreciate it. One, I'll say I'm honored to be and humbled to be sitting in this seat representing the employees here at Nashville General Hospital. In your board packet, it's my first stab at a board report. Christy Lamb is our employee spotlight, and she couldn't be here at this board meeting, but I will bring her to the next one. We have made that commitment to bring her to the next one. Bridge Builders is a program I want you all to be aware of. They are a nonprofit organization that has partnered with us. They have provided us lots of donations in the year of 2024, as well as $20,000 to the Nashville General Hospital Foundation to support mental health patients, and our own Dr. Bullock is the newest member of their board. For our strategic initiatives and partnerships, Christy did give an update on our professional services agreement. I believe that we are proud of the progress that we are making there. That team has met on March the 12th as well as yesterday on March 26th with the two subgroups that she mentioned, and we are just excited about the forward movement that we've been able to make in just such a short period of time. For challenges and recommendations, the finances have been discussed quite extensively here tonight. We appreciate the support of all of you for the supplemental to get us through June, and we're committed to the cost strategies to make sure that we make it through June 30th, and there's more to come on that. Our budget request for fiscal year 2026 is $66 million, and so we do need support to promote full funding of that. And then I also listed just a few high priority needs that were elevated by our facilities director, and I provided Dr. Martin a list and cost out for those 3 items. One thing I will also mention when we talk about patient experience scores, because I hear you loud and clear, Mr. Lester, we do need some upgrades to the facility to facilitate some of that work and increase the experience of our patients here. I think when you look at nurse communication and doctor communication, we have really high scores in those avenues. But when you look at our comments, the facility is a problem. And so we do need help with some structural things and patient experience things to elevate that as well as our response rate. Just upcoming dates, Doctor's Day is Sunday, March 30th, but we will be celebrating that with our physicians here on the 31st. And then, of course, I always like to just share Nurses Week and Hospital Week, which will start in May. I provided in the packet also just a new operational snapshot that I would like to include in the report, which just gives you just a quick snapshot of our operations, our clinic visits, our ED visits, our hospital admissions, hospital versus OBS as well, our deliveries, and as our surgery volume. And it's just a quick glance that you'll get. In the operations report card, we've provided 2023 and 2024 scores of those things that you see in like public view. One of our initiatives will be to look at the CMS star rating metric and how we can improve that. That's something that we haven't focused on as an organization, and I'll be working with our quality department on what we need to do to increase that star rating. The rest of these are more about our HCAP scores and our employee engagement scores. And all of these metrics, when you look at the operations report card, are surrounded by our pillars, which are people, service, quality, and stewardship. We do have a strategic plan that we are drafting, but we want to get with a couple of you guys when we're talking about that to ensure that's the direction before we publish it out, but there'll be more to come on that as well. Any questions for me at this time? Thank you again. Thank you for your kind words.
Mr. Chairman, may I offer a comment at this point? First of all, thank you, Dr. Elders, and thank you. We met, I guess, last week and have scheduled a routine meetings, which I look very much forward to. And I do appreciate, as others have said today, that members of the executive leadership team have reached out and all are expressing an excitement about the time moving forward. I think it's an extraordinary opportunity to do the reset we've talked about in the last 5-6 weeks and really move forward, keeping in mind every single day, every moment that we're here to provide a service to the people of Nashville and to do an even better job every single day. That's why I'm so hung up on those numbers. I also want to add, Mr. Chairman, thank you for recommending my appointment to the Foundation Board. I think that process is moving along. They'll finalize that sometime next week. I've had discussions with the chair and other members of the foundation, and one of the things that I want to make sure that this board is comfortable with, I hope you all will be, I think it's very, very important that the foundation not act in a rogue manner in raising money for projects that they think are important, which is an honorable thing, but it ought to be about what is most important in collaboration with the hospital leadership and the hospital authority itself. This isn't about operating separately. This is about teamwork and moving forward in a collaborative way that can be helpful to everybody and make sure that the money that's raised is put to the best possible use for our people that we serve every single day. Thank you, Mr. Chairman.
Thank you. Any other comments?
I just want to thank Dr. Elders and the leadership team for rapidly holding things together and making all the changes they made. It's been remarkable. I mean, the idea that they're able to work on the PSA and get it close to where it is now, that couldn't be done for so long. It's just a testament to their collaborative spirit, and I commend them. And I was also impressed with all the work about the workforce planning and forecasting that the finance team did. I think it's going to place the hospital in a better place. I think the way the leadership is working with the board is going to get us to a great place, and that has been missing for so long. And I'm very happy about this new direction. Thank you.
Thank you all for your comments. Our next meeting is April 24th, and then that, we're adjourned.
This has been a service of the Metro Nashville Network. If you would like to see this presentation again, or for more information on this and other programs, visit nashville.gov.